Hello, everyone, and welcome to WEDI Survey Insights, the state of interoperability and prior authorization in healthcare. It's my pleasure to introduce Robert Tennant, Executive Director of WEDI.
Thank you, Michael. Let me add my welcome. We have a very exciting program ahead of us today. We'll start with just walking through a few slides, giving those folks who aren't familiar with WEDI just a glimpse into our organization. We were formed way back in the first Bush administration in 1991 by then Secretary of HHS, Dr. Lewis Sullivan, who was a practicing physician. He knew firsthand some of the challenges that providers and health plans faced in trying to exchange clinical and administrative data. So he literally brought into his office some of the leaders in healthcare and charged them with developing some approaches to standardization and ways to improve efficiency. So he created what he called the Working Group for Electronic Data Interchange, and they produced two reports which were folded into legislative language, which became what you all know as HIPAA. And we were named in the law as an advisor to HHS, and we've continued to be in that role ever since. So we have a great working relationships with ASTP ONC, with CMS and OCR. And in fact, ASTP, ONC, and CMS both serve on our board of directors. We are a multi-stakeholder group. We represent health plans, providers, vendors, all of the standards development organizations, both state and federal government, and patient advocacy organizations. We have 17 health information technology focused work groups, sub-work groups, and task groups. And very simply, our role is to bring the industry together, to collaborate, to educate like we're doing here today, and to influence, hopefully driving the industry forward to improve healthcare. We get a lot of our work done through our volunteer groups. We have now 18 groups. I'll explain why we've added one, but we have most of the HIPAA transactions covered by one of the work groups, including claims and payments, attachments, claim status. But we also have a task group focused, for example, on the No Surprises Act, which is very active and really seeking to improve the data exchange provisions included in that act. We also have health equity. We've got privacy and security. We've got genomics. So we've got a lot of topic areas covered. And again, that is where the bulk of our work is done directly in these work groups. I wanted to focus very much on one of these work groups, that is the prior authorization. We have really a robust discussion every month. It's led by Heather McComas with the ADA, Janice Bakos with Aetna, a CVS health company, with Raj Gadavarthi, who is with MCG Health, and David Delano, who is with the Massachusetts Health Data Consortium. If you're interested in getting involved in this or any of our work groups, please contact Ariana Poole at apool@wedi.org. I will say we have just recently stood up a brand new work group. We're calling it the Patient Experience Work Group, and it's a wonderful opportunity to engage patient groups in particular in the idea of how can we improve data exchange when it relates to the patient, whether it's telehealth, web portals, APIs, security issues. There's lots of opportunity to engage stakeholders, again, to make a difference. And with that, I am absolutely delighted to turn the program over to our board chair, Mary Lee Stein from Aetna, a CVS health company.
Hi, everybody. Welcome to this overview. The survey was created. The reason that we did the survey was in response to the CMS interoperability and prior authorization rule. We all informally refer to that as 0057. It was published on February 8th of 2024. The final rule adds several new provisions to increase data sharing and reduce overall payer, provider, and patient burden through improvements to prior authorization and data exchange practices. They include patient access, provider access, payer-to-payer, and prior authorization APIs. As far as requirements, the impacted payers are required to implement these APIs by January 1st, 2027. So 2 years out, less than 2 years now. It's coming up quickly. The other thing that this final rule does is requires covered payers to publicly report designated prior authorization metrics by January 1st of 2026, next year. The survey was developed with assistance from the WEDI prior authorization sub-workgroup, and Rob just introduced those folks a little bit ago. So who took our survey? We had 4 groups taking the survey: providers, payers, clearinghouses, and vendors. And you can see that we had a variety of representatives from those 4 demographics completing the survey. We had 21% and change providers. Payers was the highest number at 44.9, almost 45%. Clearinghouses at just under 10, and vendors at 24.2. And you can see the total number. We had a total of 243 respondents. So the first group of questions that we're going to go through are the provider survey responses. The survey was broken up into demographic areas, and then there were also questions that applied to all. So we're going to start with the different demographics, and then we'll go into the questions that applied to all. So the first one that we're going to go through is those provider survey responses. So what type of a provider is answering the survey? So we had, again, a variety: a hospital, single location hospital, health systems, group practices, single clinician practice. We didn't have any ambulatory surgery centers, but we had a good variety of types of providers that were filling out the survey, which was good. We want to see a range of different respondent types in each of these demographics. So we asked them for the top 3 items in the final rule that they feel are issues in terms of difficulty. What are the top 3 things that they feel are going to be difficult are going to be causing difficulty as far as getting this implemented? So the top answers: funding, which I think goes across all demographics; determining a cohesive enterprise strategy for interoperability. It's kind of a new concept. So yeah, sorting out the various networks and how they interplay. We've got TEFCA, we've got QHINs, we've got health information exchanges, et cetera. And this is new to a lot of people. A lot of people don't have experience with this. So we're having to build internal expertise in those provider areas. So that's the difficulties. That's the things that are opportunities. Some we can work with, some we can't. Can't give them money. So here's the provider survey responses for some additional questions. Rate the level of importance to your organization of implementing a FHIR-based solution for prior authorization. And the highest answer here, almost split between 2: very important or extremely important. So we can see that providers, when they're looking at the concept of implementing FHIR-based APIs, they feel it's generally important. You know, almost all of the answers were really between very important or extremely important. For your organization to invest the resources necessary to implement the CMS 0057 final rules prior authorization provisions, how important will it be to have the majority of payers you contract with support the prior authorization API? And again, the majority felt that this is very or extremely important. The payers need to be on board to make it worthwhile for them to invest the time and money. In the CMS 0057 final rule, the inclusion of drugs as a component of the payer's medical benefit policy in the prior authorization API is not required. How supportive are you of payers including drugs in the prior authorization API? Again, very or extremely important to a provider. That's a clear winner. So then we're asking, you know, about the plans as far as it applies to the provider implementing this work. Do they plan on implementing FHIR only, FHIR and X12, a hybrid plan, or are they unsure at this point? The majority at this point are unsure. Those who have made a decision plan on using FHIR and X12, and a small number plan on FHIR only. So where do they think they'll be where do they think they can guess they'll be as far as January 1st, 2027? They haven't yet started for the most part. 10% think they'll be fully completed. You know, so it's clear that the industry could probably use some more time, might be the way to say that. And cost. What's the estimation for the total cost for your organization? The majority don't know. And then from there, it's a split. And just my own take on this, I suspect that some of that split may be our different demographics, and might be guesses. I am not going to speak for these respondents, but we do have a very wide variety where beyond the unsure, it's pretty flat. CMS 0057 rule includes a requirement that covered payers make available patient information via a provider access API. How likely is it that your organization will implement the provider access API? So we had over half saying it's either likely or very likely, some unsure, and some with low likelihood or will not. Somewhat likely is in there as well. So they think they will, but time will tell. Rate your level of confidence that your organization will implement the final rule API provisions by the January 1st, 2027 date. And it's almost the same likelihoods. And I think, it's hard. There was a lot of unsure folks on the slide before, and they think it's somewhat likely. So I'm sure they're going to do their best to get there. But, maybe some gaining expertise can help them get there sooner. So let's see. We're into payers now. And these questions will kind of take a similar format. So what lines of business do we have? And we did have a pretty wide variety, except we don't have a lot of the property and casualty, workers' comp, or auto. So the winner here was Medicare Advantage. Medicaid is also well represented. as well as some other federal programs. We have commercial did respond, although they're not required to implement this as far as the letter of the law. And then some other types of insurance as well. And this is good because we want the respondents to be the focus of the rule. Does your organization participate in federal payment programs that would require you to comply with the CMS 0057? Yes, for all lines of business, yes, for some. Between those two, we have the vast majority of our respondents. So of the following implementation issues, what do you expect will be the 5 most challenging for your organization? I don't know why I feel like I'm losing the bottom of the screen. The top 5 are determining a cohesive enterprise strategy for interoperability, which was also a concern for the providers. Digitizing prior authorization policies, because this is part of the payer requirement. Sufficient funding. All demographics are probably going to see that one. Meeting the compliance timeline and developing new workflows. They do sound familiar from one another. In the final rule, the Health Level 7 Da Vinci implementation guide for the prior authorization API is recommended, but not required. Rate your level of knowledge with this implementation guide. So, somewhat knowledgeable and fully knowledgeable have a fair representation, and slightly knowledgeable has a pretty good representation as well. There's very few that have no knowledge whatsoever. So there is knowledge within the payer community of the implementation guides. That's a positive. Which of the following best describes your plan to implement the prior authorization API? The majority plan on using FHIR and X12, with slightly fewer being unsure at this point in time, and not far behind are planning on going FHIR only. So there's been a good number of decisions, on FHIR or FHIR and X12, but we do have a third of them still not quite sure. In the final rule, the inclusion of drugs as a component of the medical benefits policy in the prior authorization API is not covered. How will your organization address the issue of drugs as you implement the final rule? Most of the payers have not yet decided. The ones that have, we do have a fair number that do not plan to include drugs. Some have decided to include drugs. So we're kind of across the board here. So more to come on that one. Which of the following best approximates where we are today regarding the compliance date? 43% have not yet started. And that's tough against a 1/1/27 date. Third, the next highest is 25% completed at 31.3. 11.9 are fully completed. God bless those people. And then we have a pretty much a little bit of a range. So this is breaking down the current progress as it applies to each of the individual APIs. So the first one is the payer-to-payer API requirement. I'm being told that people can't see it, although I can.
I can as well.
Okay. Whoever that is may want to go out and come back in. Okay, for the payer-to-payer API, 41.2 not yet started at the highest number, and 26.5 are at 20% completed. The next lowest is 14.7 at fully completed. The numbers are pretty close moving down. Provider access API, 48.5% not started yet, 20.6% at 25%, and 11.8 fully completed. Patient access API, 32.4 not started, 17.7 are fully complete at our second highest number, which is impressive. The readiness to publicly report PA program metrics, 25% not yet started, 26.5% are a quarter of the way there. Here's the money. What's your expectation of the incremental cost for the organization to implement the API components? 34.8% estimated $1 to $5 million. And then we have a spread from there with 24.6% saying they're not sure. Of those costs, what portion of your costs will be associated with implementing the prior auth API alone? And 39.1 said they're unsure. And then we have kind of a spread from there. And the highest of the spread is 27.5 saying that half the cost would be attributed to that single API, which is interesting. It's going to be a lot of work. The payers who are not required to comply. So, for example, the commercial payers, what is your organization's position on implementing these individual APIs? So for prior authorization, the highest response was our organization is currently considering implementing. Payer to payer, we were split here between unlikely and considering. Provider access, same thing. Patient access, we're currently considering. So it's interesting. We didn't get any decisions of not doing it, which is a positive, I think. Annual gross revenue, just to give us an idea of that piece of demographic, 26.3% of our respondents have revenue of less than 10 million a year. 42.1 are the extra large, and then 31.6 were large. Will your organization assist payers and or providers comply with the API provision? Oh, I'm sorry, we moved on to clearinghouses, my bad. Will your organization assist payers and or providers to comply with the API provisions included in 0057? Vast majority said yes, 82.4%. 10% were unsure. 5.3% have no plans to do that. Excuse me. Moving on. Which of the following best describes their plan to implement the prior authorization API? 81.3% plan to implement both FHIR and X12, with 12.5 plan to use only FHIR API. That's interesting. Now we're on to vendors. What type of vendor are you? Practice management system, electronic health record, acute care, solution provider, data analytics. The vast majority chose other. From there, EHR was 20.8%, practice management system 15.1%, and then data analytics followed by acute care solution, HIS or specialty. Which of the following best describes your footprint? Vast majority national, followed by regional and then state. Will your organization assist payers and or providers comply? Almost 82% said yes, 16.4 said no, and a small percent said no. 16.4% said unsure, and a small percent said no. Do you plan to support, on behalf of your payer customers, the prior authorization API? 3/4 almost were yes, small number of no's, some unsure, and 10% it's not applicable to them. Same question for providers. 55% said yes, 22.5% said no. They are not going to support the provider side. 14.3% are unsure. And again, we had some that it's not applicable. So on behalf of payer customers, are they going to support the provider access API? And it's funny that we're have this the 55.1% say yes, 18.4% saying no, they're not going to support the provider access API for payers, 18.4% unsure, and then the remaining are not applicable. And the provider access API for provider customers, half said yes, 1/4 said no, and the remainder unsure or it does not apply to them. Do you plan to support, on behalf of your provider customer, the patient access API? Evenly split down the middle between yes and no, followed by unsure, and then not applicable. Do you plan to support, on behalf of your consumer customers, the patient access API? Almost evenly split between yes and no, with the yes edging it out a little bit, followed by unsure and not applicable, which I thought that was interesting, personally. Moving on. In the final rule, the prior authorization requirements are not staggered. This is a 1 day, all due at once. They're all due on January 1st, 2027. Rate your level of support for staggering implementation of these requirements, with the CRD coming first, then the DTR, followed by the pass. 26% were supportive, 24% were very supportive, with 11.3% being moderately supportive. 19% were not supportive at all. 8% were only slightly supportive. So we do have a range within the supportive, with almost 20% being not supportive. So overall, the and this is all respondents, the respondents are generally supportive of the staggered implementation concept. Again, for all of the following educational options, select up to 3 that your organization would find the most helpful related to 0057 to help in your implementation decision or process. The top answers out of the list that we gave here, which is probably an eye chart thing for you: education on industry best practices, education on workflow design and modification, and advanced education from a technical perspective on implementing these APIs. And we have some comments coming up as well related to this question. Some of these comments, there was comment related to DTR documentation and requirements. That doesn't seem as much education. There's a suggestion that a better understanding of the intent of the role that payers are intended to provide with relation to providers, how this role is different from the TEFCA, QHIN, HIE, because this is a new role with it being an administrative transaction. They could use education on the interaction between providers and payers through intermediaries, education on the Da Vinci IGs, which we heard in some of the slides earlier on their top education items. Moving on. From a program perspective, these are general comments about 0057 as a whole. From a program perspective, this is a lot of heavy lifting when there are multiple competing priorities. It's not impossible to meet, but it is challenging. It's a massive amount of work. It's highly unlikely that we'll be able to meet the timelines. We strongly encourage pushing for delay. We're still waiting for internal approval for systems higher up since federal funding is frozen. That speaks to the new. I'm assuming this speaks to the new everything on hold. Word fails me. President, yeah, it's right there. Moving on. Another one, need more time. This one is supportive of staggering the implementation. Here's an important one. Independent physician practices and independent physician organizations that are already operating on a very lean budget will be impacted by these requirements. And that's a very real issue. Small providers, single doctor offices, they're probably not even aware of this. Scaling connections between providers with payers has not yet been resolved. It doesn't seem to me that CRD, DTR, and CQL components will be understood. I don't know what CQL. Somebody has to educate me. Will be understood and implemented in time to meet the timeframes required by CMS. I'd suggest an interim solution that involves a simple query for which items require prior authorization and the ability to retrieve fillable templates. As more contracts have value-based care and related tie-ins, we want to make sure that we're not missing patients or including patients we should not in our clinical solutions as we farm out some services to third parties and intermediaries that cost us on a per patient basis. We want the right patients to get the right additional care and get paid for that care correctly. True. This person thinks that instead of APIs, it should be digital workflow. And no one at our organization is engaged with the business stakeholders to determine the process improvement. And a general statement that we need clarification on many items from CMS. And join the prior authorization sub-work group. They meet the third Tuesday of every month from 2 to 3 Eastern. Rob?
Excellent.
Tossing to Rob.
Yeah, Marilee, thank you for walking us through all of those results. I think what folks can see is very interesting responses from the industry. So what we're going to do now is transition over to our panel of experts. And if my panelists can come on camera, we'll begin the questions. We have an august group of experts. I am absolutely delighted to have these folks. So I'm going to have them each introduce themselves, and I'll go by closest to me on the camera. We'll start with Heather. Welcome and thanks for joining us.
Hey Rob, thanks so much. I am Heather McComas. I am Director of Administrative Simplification Initiatives at the American Medical Association, and I'm also pleased to serve as one of the co-chairs of the WEDI Prior Authorization Sub-work group.
Excellent, thank you. And Raj?
Hey, my name is Raj. I'm one of the DaVinci HL7 DaVinci co-leads and also technology and interoperability expert at MCG Health. I'm very excited to be part of this discussion today.
Excellent. Welcome, Raj. Karuna, welcome.
Hi, everyone. I'm Karuna from Blue Cross Blue Shield Association, where I'm a business interoperability lead. I'm also a co-chair for the Payer and Provider Information Exchange HL7 work group. So thank you for including me today.
Excellent. And special welcome to Jim. Jim is a brand new member of WEDI, and we're thrilled to have you and your colleagues join.
Great. Yes, Jim Denier. I'm the Interoperability Director for Independence Blue Cross, and glad to be able to support this.
Excellent. Well, Jim, I'm gonna start the first question off to you. Obviously, a lot of data included in the survey. Was there one particular point or two that jumped out at you in terms of perhaps a little bit of a surprise?
There's a couple of surprises in there, not too many surprises, but I thought it was interesting that 25% of plans plan to include drug prior authorization. So I thought that was interesting. And that 40% of them plan to use support both FHIR and EDI. So I had to give that some thought for my own system. And you know, the providers clearly want drugs to be included in prior authorization, 50%. So that seemed like a high number. Wasn't expecting.
Excellent, appreciate that. And I will note that including drugs is also included in the unified agenda that came out in September, where it's just kind of a placeholder list of regulations that the federal government is working on. So we could see that at some point. Karuna, I'll go to you next. What jumped out at you in terms of maybe a surprise for you?
So I would agree with Jim. Overall, relatively consistent with what we're seeing as well. I thought it was good to see that achieving executive buy-in is not an issue, and I thought that was relatively consistent with what we've been hearing in some of the HIMSS work group sessions where there was not a concern with the lack of confidence in the marketplace. So I felt like that was an overall positive. But then what kind of struck me as surprising from there was just the sufficient funding issue. So maybe not super surprising, but intriguing in terms of just, what's the holdup? Is it the capital investment? I know we saw many plans are planning investments upwards of $1 million up to $5 million. Is it the high-priced expertise, lack of incentives? So that just struck me as something interesting, given the confidence in the marketplace that some of these capabilities will be invested into.
Yeah, and just so folks know, WEDI will be reprising the survey on a regular cadence up until and perhaps even after the implementation date. So I'll be interested to see if the cost figures change over time, if things get more expensive. Raj, from the vendor perspective, what jumped out at you as a surprise in terms of the survey results?
Yeah, so looking at the 43.3% said we're not sure where we stand in terms of meeting the dates. Didn't surprise me too much, but I was, last year, Q3, Q4, there were so many customers talking about these things, but not yet started is really alarming.
No, good point. Heather, from the provider perspective, anything surprised you in terms of the results?
I think I have to piggyback on Raj and say just the both from and the provider responses and the payer responses, the high numbers of not yet started was surprising and maybe disappointing. I'm not going to completely surprised. I think particularly for those of us who work in this space, there's so much energy and attention. We spend a lot of our work days talking about implementation of this rule. And then to hear so many people, on the peer side, 3%, I think the provider side was like 51% saying they haven't even started yet when the science deadline is, moving from my perspective, pretty quickly. That was, disappointing to see. And it does make me worry about things being ready to go in a successful way at the beginning of 2027. I said it before, but from a physician perspective, if the technology is not working well from the get-go, that's going to really hinder and discourage adoption. And I'm worried that the physicians and their staff, that the APIs are not working well in the beginning of 2027. They're given a couple shots and they're just like, I don't have time to monkey with this glitchy stuff, and they're gonna abandon the technology, which is not what any of us want.
Let me follow up with you. One of the things we're watching for is the ASTP ONC certification program. It was proposed in HTI2, but has not been finalized. Heather, what could that mean to the providers if the APIs are not folded into the certification program, or if they don't move forward at all with the certification program? Could that serve as a deterrent for providers going forward?
Absolutely. I'm glad you raised that point, Rob. The bottom line is, and just to put it in very simple terms, if there's not a EHR certification requirement on the APIs, providers are going to be basically in the position where they do not have the tools they need to be able to take advantage of this technology, which is, very disappointing. It's disappointing because, as we saw from the survey results, physicians and other providers really want this technology. They want to improve prior authorization. They want it to be less burdensome. And certainly they want the patients to get care faster. But if their EHRs don't support the technology, they're not going to be able to take advantage. But even more concerning is the fact that the CMS MIPS program is going to have a measure that goes into effect beginning of 2027. That's going to be an attestation about whether or not the physician is using the technology. And so they're going to be basically measured on using this technology, but they might not even have access to it. So there's kind of a stick there, but they don't even have the means to fulfill that requirement. So again, it's a real concern, and we're hoping that this kind of MIA regulation resurfaces soon.
Yeah, great. Let me turn, Jim, next to you. One of the top concerns raised by payers is the digitizing of prior authorization policies. Not to put you on the spot, but is that a concern for you? And how are you addressing that issue?
Yeah, it certainly is an issue. I mean, this is why I feel so strongly that this is going to require a lot more business involvement than maybe sort of other sort of mandates that health plans typically deal with, which are often sort of IT sort of efforts to turn on an API or create a report or something like that. This is hitting at the very heart of the sort of operational side of how health plans and providers exchange information, and the medical policies, at least in many plans like ours, probably need to go through some sort of codification process so that we can build some logic around supporting these kind of APIs and the interacting with providers, so they get a consistent experience.
Excellent, excellent. Raj, you're in the trenches on this. What are you seeing from the vendor perspective on digitizing these policies?
I think in addition to all the APIs that they have to build converting all the hundreds of PDFs and different forms they manage on a quarterly and yearly basis. And then they work with vendors like us at MCG Health, and there are a few other vendors. So all these years, Rob, these policies are there for a reason, and they have a flexibility to change things as they go in the process to make the determinations based on their business needs. Now, you create an additional content management process to turn them into a digitization. And then on top of it, the spec says you should also support CQL, which is digitizing that intent of the content in terms of what data sources you would need from the provider and perhaps from anywhere. When you combine both of them, it feels like a behemoth. It feels like a lot they have to have. Having that kind of technology to build, to digitize once and to support the CQL comes out of it, and then on top of it matching. We're asking a lot to these payers, and they're really struggling. So there are a lot of vendor solutions out there. They're building some of them out there, but I think they're going to get there eventually. They need it, but they have to take probably what is the highest volume first. So that's how we approach our customers, because you're not going to change all your 1,000 policies overnight. So
yeah. No, excellent. Karuna, let me ask you about the another challenge that was identified by health plans, and that is trying to determine a cohesive enterprise strategy for interoperability. That suggests that health plans are looking at a broader viewpoint of APIs than just how can I comply with the letter of the law. So what are your thoughts, and what are you hearing from your member plans?
You're definitely nailing on kind of the heart of what this policy is really putting payers in the situation of, are we just checking a box, or are we really thinking about strategic investments? And I think what payers are seeing and realizing very quickly is it's going to be a heavy investment either way. So it makes sense to sort of take a step back and reassess what investments were made with 9115 and sort of what are the goals beyond compliance as it relates to the different APIs. So I think we're excited to see that our plans are really seeing this as building a foundation upon which clinical data can be used more effectively across the entire organization. So going back to the drawing board with deciding things like build versus buy, there's quite a few different vendors out there that are shifting their focuses, quite a few different components that are involved. So folks have to decide where they're best suited to build in-house versus outsource. Really exciting to see that a majority of the vendors and clearinghouses are planning on supporting both payers and providers with the API capabilities. I think, as we know, the mandates don't require them to, so that'll be a big value add for their customers as payers and providers. And then in terms of, just thinking from a bigger picture in terms of what are the opportunities for reusing some of the architecture, I think where some things may have been built in silos or for individual use cases, there's really opportunities to think about reusing that architecture and then baking in sufficient funding for the long term in terms of both incentives for the adoption by providers and members, and actually having that technology being used, and then costs for ongoing support while measuring business value ROI. So definitely a little concerning that there's such a high percentage of folks that haven't gotten started, but I think in a way there's some positive silver lining to plans actually thinking about it bigger picture and making sure that those investments are long term.
I appreciate that. And maybe I'll pick up on something you just mentioned, that there is a significant number of providers and plans that report that they've not yet started. Is there anything that jumps to mind? Maybe Karuna, I'll start with you. How can we as an industry convince folks that are hesitant, that are waiting, hoping perhaps it goes away? I think what you alluded to is looking at this as more than just a compliance exercise, but a completely new way of approaching data exchange. What can we as an industry do to help them?
So one thing I'm a big advocate of is just lowering the barrier to entry. I think, historically there's often been costs to get involved with piloting exercises or pilots. Now there's a lot more resources like the Trebuchet Project, I'll make a plug, to actually be able to participate in an ecosystem and learn from peers and get some of that hands-on support to navigate some of the questions like what are the roles of QHINs, and what's the difference between a payer partner and a QHIN. So I think lowering the barrier to entry and really improving the education opportunities. We're all kind of learning as we go, and there's a bit of a drought and a need for curated educational opportunities that we can all come together, opportunities like these WEDI conferences to share what's out there and where to get involved. I think, the more we can improve confidence and lower the barrier to entry to failing on our way to success, we'll kind of see those percentages really tick more and more towards likely and confident to be ready as time moves forward.
Oh, that's great. And Heather, maybe the same question from the provider perspective. We talked about, it'd be great to have a certification program in place that would drive the EHR vendors. Absent from that, what can the industry do to really jumpstart providers in this area?
I think that some of the survey results actually kind of hint at that, and I don't know if others would agree, but if we can actually have these APIs cover all lines of business beyond those that are strictly mandated by the CMS rule, that would be really enticing to providers. We saw that in the survey results, overwhelming majority, that's what they wanted. If they put the investment into technology, they're going to be able to do prior authorization business with every single payer that they engage with, not just the government regulated ones covered by the rule. That's really enticing. Also, we saw in the survey results that if drugs were added to the scope of the APIs, that would be very attractive. We know that, many of the medical benefit drugs that were sadly excluded from the scope of this rule require prior authorization. They're expensive things, biologic drugs, specialty drugs, chemotherapy drugs. So I think that if we, as an industry, think about going kind of above and beyond what's strictly required by the rule, that would kind of sweeten the deal for providers and encourage them to make the investment in this technology.
No, that's great. And Jim, I'm going to take advantage of you being a payer in this space. When you think about a business approach, are you asking yourself, and is your company looking at this sort of broadly speaking, how are we going to move to APIs and change the way that we've been exchanging data? How do you look at this as a plan?
So I think I think of mandates traditionally as being sort of a check the box kind of thing, deliver the minimum viable product. This rule is different because it included that the electronic prior authorization, and I think the only way that this is going to be successfully implemented at plans is if we engage the business team that's responsible for that utilization management, for setting medical policies. If they're not fully engaged in addressing this need, and clearly the survey pointed to providers are wildly enthusiastic about having this option to get away from portals, to get away from it's this plan, but it's this kind of procedure, so I have to go to this other vendor that the plan's designated. The idea of presenting a single pane of glass to the providers is not only attractive for the providers, but it's very attractive for plans as well. We can reduce provider abrasion, reduce member abrasion, make it a better experience across the whole ecosystem. So you can't make these kind of changes without getting all the operational team members involved. So.
That's excellent. Raj, I'm going to give you the last word on this. Obviously, you're working directly with a wide variety of plans. are you seeing them embrace, as Jim said, this sort of new vision on how to do business in healthcare?
Based on 3 implementations we have done and few others in progress, everybody is very cautious in terms of how much money we are going to spend before we see the outcomes, because the technology revamp, the utilization management team bringing into the table, like Jim said, there are a lot of organizational barriers. I see it. So the latest trend I have seen with the few customers we are working, they're taking like good amount of time, like Karuna said, defining the enterprise strategy, architecture, and starting small. That tells me that they're less worried about the date. They're like, anyway, we have to do it. Anyway, we have to revamp this whole thing. This is a good opportunity, but let's do it slowly. And also, they're looking for others to share where they're failed at. Right? For the 3 implementations we have done, one took like 18 months, one took 8 months. So they're okay with it as long as they understand, But some of the new customers we talked to recently, they're like, we are going to give something in 3 to 6 months. We're going to cap the investment there. Even that means revamping some of the digitization efforts. And they're building a more of a 3 to 5 year roadmap based on what I see. Even the people say it is 24 months. You can tell it's going to be 3 to 5 years. Personally, I like that approach because we have been very aggressive last 2 years, and the outcomes are not there because the providers are not there yet.
Excellent. I think with that, we'll close the panel, and I think, Michael, we've got a couple of more slides to go through, but thank you, panelists, for your insights. The bad news is we're going to invite you back the next time we do a survey, because we want to keep tracking to see how the industry is doing. And again, a pitch for our prior authorization sub-work group. We are getting our hands dirty in these sub-work groups, and it's a great opportunity to learn and to share experiences. I think, we're all in this together, and the only way we're going to have success is if we work as a team. We can't be in silos. We've got to work together to solve these problems. So with that, I did want to remind folks that we have a series going on this year, as we did last year, on the 0057 rule. The next iteration is on June 11th, and it's going to be focused on providers and EHRs. It's free to the industry, and we encourage you to spread the word. We're going to have a very robust discussion focused on provider readiness and what EHR vendors can do to make things smooth in terms of implementation. And go to the next slide.
That's the last slide.
Oh, last slide. Okay, with that, I think we can close today's event. First, I wanted to thank a few folks. First, our board chair, Mary Lee Stein, thank you for walking us through what is a very interesting set of results. And a big thanks to our panelists, Jim, Heather, Raj, and Karuna. Wonderful insight and perspectives. And again, get involved with WEDI, get involved with making things better. And we look forward to seeing you all at future WEDI events.
And thank you to Rob and Michael for everything that they do as well.
Appreciate that. Have a good rest of the day.
Take care.